association with a reduced mortality. So we looked at bundle compliance and how we could use this work. Bundles can be seen to improve compliance. In the ICU environment, we've seen it with ventilator-assisted pneumonias, associated pneumonias, and central line related infections. There's been multi-centre trials, and even some of our own data, which is being presented elsewhere this afternoon, looked at the reduction in central line related infections by the implementation of an insertion bundle, a monitoring bundle, and an insertion pack. We know that standardisation of basic interventions can help, and that's seen in theatres with the WHO surgical checklist, and also further afield in lots of military and civil aviation. Examples lead weight to this argument. But could we apply it to sepsis? We did an in-house audit that looked at 70 patients being admitted to the ITU, and we found we only had 34% compliance with resuscitation bundles. So there was a lot of work to do. Our hypothesis was that could a sepsis response bag provide a standardised and measurable approach to sepsis? Would the sepsis response bag improve the compliance with the delivery of sepsis 6 in the room setting? And could it save time and help achieve the 1 hour intravenous antibiotic administration? So we had a prospective quality improvement study held at the Royal Glamorgan Hospital. The Royal Glamorgan Hospital in Ladris in South Wales is a medium-sized district general hospital that has 500 beds, 6 ITU and 4 HDU beds. We placed the sepsis response bag on all wards. This contained all of the equipment needed to administer the sepsis 6 in one tidy bundle, along with associated paperwork, some guidelines for its use, some guidelines for the antibiotic administration. We thought it was a simple solution, a one-stop answer. It was a proven research-based response. It had low cost associated with it. In fact, it had to have no cost associated with it because we weren't allowed to spend any money. The antibiotics were made available on every ward. We were using the sepsis 6, 3 diagnostic and 3 therapeutic arms. You give 3 and you take 3 away. There's the bag in its full glory. It's not particularly exciting. It is all normal equipment, but it's all just put in one place in a bag with the relevant instructions to use. Unfortunately, we weren't able to maintain the antibiotics with the bag themselves. They had, due to medicine pharmacy problems, we had to make sure that they were locked away in a cupboard. So they were close by in a cupboard that had a sign on it telling us exactly what it was. And that contained all the antibiotics that microbiology asked us to include in this pack. So our method was, we took the severe sepsis screening tool and sepsis 6 care pathway, and we adapted it for our use. Wales has adopted as a whole an early warning score called NEWS, the NHS early warning score. That itself has sepsis highlighted in it, and every patient who scores a NEWS score above 2 should be screened for sepsis. We then looked at every patient who had 2 of the SIRS criteria plus a septic source, and we treated them using the sepsis 6 whilst we were monitoring for signs of organ dysfunction and shock. The data was collected using a standardised pro forma, and the sepsis database was established by us in the outreach team and in ITU. We underwent a rigorous training programme for all members of the multidisciplinary team, focusing on nurses and junior doctors. All patients were monitored and followed up by the critical care outreach team. So, were the bags used? Well, yes they were, and they were used right away across the hospital, that's all of our wards. The areas where they weren't used weren't particularly that much of a surprise to us. There was 2 of the short day surgical wards, and also down the far end areas where the critical care outreach team doesn't have that much of a sphere of influence. Our patients ranged from an age of 16 to 92 with a mean age of 65. Our results, well, across an 18-month period, we opened 170 bags and used them. Out of 170, 130 of those patients received the sepsis 6 with 1 hour. That gave us an overall compliance of around 77%. However, if you look then at that's 7% within 1 hour. But if you looked at the 3-hour time band, we managed to get that compliance up to 94%. If we look at the individual bundles, or parts of the bundles, the main areas where we fell down were antibiotics, administration of antibiotics and IV fluids. And that's because the critical care outreach team prescribing is not in their remit, so we needed medical staff to come on and get on board and help us, and that obviously of the equipment was nice to have it all in one place. And we did find that if you then looked at the 3-hour band, the administration of antibiotics and fluids actually went up and came up to nearly 94%. We had a statistically significant difference in our news score at 24 hours. Our patients, when we saw them first, they ranged from the score of 1 to 13, with a mean of 7, and the biggest drop we saw at 24 hours was -8. As our 24-hour showing slightly differently, 76% of our patients remained in ward care and on the ward environment. 17.5% of them were escalated to HQ, and 6% were either made not for research and therefore not for further follow-up, or they did die. The different bands indicate whether we consider them to be positive or negative outcomes. So for the ward-based patients, those are the patients, the red bar is positive outcomes, as in they showed us a large drop in their news score and improved patient within 24 hours. In the ITU environment, it's whether they made it to ITU within 4 hours or not. Looking at our hospital outcomes, nearly 60% of our patients were discharged home from hospital by admission. We had just under 23% who died as part of this hospital admission. 14% of those patients were transferred out, transferred to one of our respite hospitals, and 4% were transferred out from the hospital follow-up. So our discussion indicates that we found possibly a new way of delivering the care in the ward environment that significantly improves the process compliance with delivering sepsis 6. The fundamental elements that didn't need any medical interventions were well over 80% all of the time, and thus the time for intervention was also reduced as all the kit was available in one place. Delays in the antibiotics and administration of fluids were because they need medical prescribing, and we're working on those things. As I said, the antibiotic prescribing is being looked at. Not only do we recommend as an in-house point of view that things we start with stat, that's the first dose should always be written up stat and given straight away, and encouraging the junior doctors to give them themselves if they're able to. We also have an all-Wales paper, the microbiology of the sepsis, which was published on Wales Sepsis Day by Higginbotham, and that recommended that for patients with questionable or questionable around an origin, we should deliver 4.5 grams of tryptophan and tazobactam, up to one drop shot of 6 milligrams per kilogram of gentamicin. The reason they use those antibiotics is looking at the Welsh resistance, gram-negative and gram-positive, it's going to be less than 2% for that group of antibiotics. The plan is to start smart, focus and review every 72 hours. We believe that sepsis bank can provide standardised and measurable approach to the treatment of sepsis. Sepsis bank is favourably associated with the sepsis condition, together with a significant drop in news score at 24 hours and therefore in further better patient outcomes. Our future plans include the rollout of sepsis bank across the whole of the health board and beyond. We're looking at also adopting a standardised sepsis documentation. Many thanks to Chris Hancock and Rails, who helped us get this underway, and Chris Suby and Ron Daniels, whose work we've